At the onset, I'd like to thank the organizers for this opportunity. After talking about CNLDO, I shall be taking it forward to discussion about acute dacryocystitis in adults and pediatric population. As we all know that it is a medical emergency characterized by pain, erythema, swelling, watering may or may not be present, and most of them are, if we talk about etiology, it is because of either primary nasolacrimal duct obstruction, congenital nasal duct obstruction, or some sort of neoplastic infiltration. Common signs and symptoms we all know. There would be redness, tenderness, there can be sac swelling palpable around this area. Usually it is below the medial canthal tendon. There can be watering associated with it. And if left untreated, it can eventually lead to abscess formation, orbital cellulitis, fistula, rupture of fistulas, as well as orbital cellulitis, cavernous sinus thrombosis in very rare scenario, but yes, a dreaded complication which we all know. So what do? We all know the conventional method of IV antibiotics. You drain. After 1 month of IV antibiotics or oral antibiotics, we go ahead with the DCR, which is external DCR. But now the talk is that we go as soon as possible. How is it possible? Because you're all going to say that in early phase, if we go ahead with external DCR, it's going to be a messy surgery, it's going to be a painful surgery, we're not going to be able to operate in the infected planes. So we go ahead with early endoscopic DCR. So we have enough literature now supporting this thought process, and the reason, for the simple reason that it gives early access to the lacrimal sac. We deal with the infection there and then at that moment, and that gives us to early recovery, lesser scar fistula formations, as well as we preserve the lacrimal pump function. So whereas in external conventional DCR method, which we used to do earlier, what happens is sometimes the infection is so bad that you keep on getting those recurrent infection, keep on getting relapses again and again, and sometimes we are not able to take the patient for surgery itself. So the point around this which we emphasize is do the surgery as soon as possible. Don't wait for the inflammation to resolve, helping us in better recovery of the patient. Yes, then there is this question whether we should do intubation or not. Yes, it is recommended in dacryocystitis. It helps in lesser granulation tissue formation and giving better results. Now coming to the pediatric population, what is it different in it? Why are we emphasizing this comparison? Simple reason being that in a pediatric population, the immune system is immature. We have valveless veins, narrow drainage system. So these kids, whenever they land up with acute dacryocystitis, they have a much more fulminant progression, giving to orbital cellulitis and abscess formation much earlier rather than adults. And sometimes they can be associated with something like dacryoceal or lacrimal sac diverticulum, again in which the treatment gets very different. So I'll go case by case in this scenario, helping you all to understand. So here's a case of a 3-month-old child who presented with swelling and discharge since 5 days in right eye. As you all can see, there is sac swelling, fistula formation. There's a definite raised meniscus height, and we all do fluorescent dye disappearance test. I do it regularly in adult and in a child, wherein we stain the cul-de-sac and we check the patient after 5 minutes to see whether it is there or it is completely flown away. So that is what we say is a FDDT. So this is a positive FDDT. As you all can see, the eye is completely stained. With this, we came to a diagnosis of right eye pediatric acute dacryocystitis with fistula formation. So now this child is 3 months old, but the child has dacryocystitis. We are not going to wait. We will plan for syringing followed by probing under general anesthesia under endoscopic guidance. I do all my probing under endoscopic guidance by default. So the first step intra-op would be regurgitation of fluid. We saw regurgitation of fluid from the fistula, whereas left eye was freely patent. On probing, we overcame the membranous stop, and following which, when we repeated the endoscopy, the probe was visualized, followed which free egress of fluid was noted in the inferior turbinate, hence giving us a patent NLD post-operative. At 6 weeks follow-up, we can see very well that the sac swelling is completely resolved. Fistula is healed, tear meniscus height is normal, and FDDT is normal. Coming to case number 2 now. This is a 2-year-old child with watering and discharge since birth. As you all can see, there is sac swelling, there is fistula formation, there is raised tear meniscus height, and FDDT seems to be delayed on both sides now. Again, same protocol was followed. The child was taken up for syringing probing under endoscopic guidance. Intraoperatively, the right eye, which was the affected eye, this wherein the swelling was there, we saw lower punctal agenesis, and on probing from the upper punctum, hard stop was felt. When we repeated the syringing, of course, there was no fluid egression because we could not overcome the stop. Secondly, there was also sac swelling noted. So when we were pushing the fluid, the sac was gradually dilating, thus giving us a clue that there was no tone to the sac. It is a atonic sac. Whereas in left eye, there was upper and lower punctal agenesis, in which we did not go ahead further with any procedure. Now, this is a child at 2 weeks post-probing. As expected, the sac swelling was still there. So the patient child was advised for endoscopic DCR with intubation. Now, an atonic sac, the sac which does not have that pump mechanism, no amount of probing is going to help. We need to go for early DCRs in this case. This is the third case. This is a case of a 1-month-old baby who came with parents, as per the parents. There was history of bluish swelling present in the inner corner of the left eye since birth, but also discharge was there. Child had fever and oral antibiotics. He was already on oral antibiotics. We all can say that there's a pus point. It's a heavily infected acute dacryocystitis around this area. Since the parents were giving history of a bluish cyst over there, we made a diagnosis of dacryocystopiosele or an abscess in the dacryocele itself. As the previous speaker has already discussed about, in such situation, the treatment of choice is probing with marsupialization of the intranasal cyst. Now, whenever we have these dacryopioceles with intranasal cyst, we need to make sure the child does not have any breathing difficulty as well, because whenever there's an intranasal cyst, there's always associated problems accordingly. And whenever it's bilateral, specifically bilateral, it is far more important. Previous speaker has already discussed about the mechanism. I'll not go into it. I'll just describe a little bit about the cruciate incision which we give. So with the help of a sickle knife, on the medial wall of the intranasal cyst, we go from superior to inferior and posterior to anterior. And following that, we do a 45-degree probe test in which we insert the probe and we literally tilt it 45 degrees to make sure that the cyst has open up. So I'll just like to conclude with these things, that in probing is important in case of early probing is the surgical choice in case of pediatric acute dacryocystitis. And in cases where there is associated lacrimal sac diverticulum or dacryocystocele or some sort of history of trauma, we might need to go for early pediatric PCR. And I would like to conclude that we need to start thinking of earliest intervention, be it adult acute pediatric, adult acute dacryocystitis or a pediatric acute dacryocystitis, with the following management. Thank you.
Well, nice presentation, Dr. Shikha. One question, that in case of case which you showed here also and you mentioned also, in acute dacryocystitis with fistula in a child, do you do syringing also?
Before taking for probing, under anesthesia, I make sure to do syringing in order to confirm the patency, irrespective of the fact whether fistula is there or not.
So, is there a side effect of doing syringing there?
We will be spreading infection is what we are trying to say, but the child is already under oral antibiotic coverage.
Not really this. Spreading infection is one part. Second part is your fluid will come through the fistula all over into the inflamed area, and post-operatively you will have increase of inflammation also and increase of swelling also.
Correct.
Like the other school of thought is that wherever you are contemplating probing in acute dacryocystitis, syringing may be avoided. So that's another way of looking at it.
So I had a recent patient, I'll tell you, whom I thought was acute dacryocystitis by the picture. One of the biggest differentials is acute anterior ethmoiditis. So when we took the patient on table, it was patent on syringing, and that itself makes us think that is it actually CNLTO?
No, see, your diagnosis has to be conforming to the clinical situation. Like there are certain points which favors the ethmoid mucocele. You have to follow the MPL guideline, whether the swelling is above it or the below it. So there are certain things, but yes, point is well taken that
acute anterior, that is one thing which we need to keep in mind.
Once a while these things do happen, sir. Even I had a 5-6 years old child. I told my resident do the syringing. They tried, even I tried. Patient was so agitated, वो नहीं करा रहा था. We took him for GA, लग रहा था वो ये. But on table it turned out to be patent. मतलब probing से पहले ही it was patent. कई
So
बार
after
once a
that
while
case,
ये
yeah.
हो जाता है sir. But मैं भी इसमें
no,
dilemma में
in
रहती हूँ.
acute, see, in a chronic case, it's fine. But if you are having a fistula with acute
I'm talking about chronic
dacryocystitis, the diagnosis
I
is
take
there.
your point,
Yeah.
sir.
Diagnosis,
Exactly,
diagnostic
exactly. I take
dilemma
your
is
point.
not there.
I am talking
All
of
right.
chronic